again, it's an indication that they need treatment for that, and it's usually pain control. Okay. Yes, but usually pain is not related to a stroke. So if you get pain, it's more likely to be a stroke mimic. Unless you've got neck pain that's led to you having a stroke, it's a little bit different. But pain, for example, if you've got pain in your arm and leg, it's less likely to be a stroke. Unless you've got neuropathic pain, because the nerve cells are not working very well, and that might come later on. So it's not for the trait. So sickle cell anemia, absolutely. So sickle cell trait, which is just the carrier, usually is not related to stroke. Okay? But sickle cell anemia is. Personally, I've been worried about either. Yeah, so I don't know. I mean, the difference is with a hemorrhagic stroke, we can't really do much with regard to clot busting medication because we can't give you something that thins your blood if you're already bleeding, and we can't go in and pull the clot out. So the time window is relevant. There are some things we can do, and that's why you still need to come to hospital. It depends on the type of hemorrhagic stroke, okay? And actually, in my experience, we don't take patients to theatre commonly. So when you have a hemorrhagic stroke, if it's deep like this one, so if you see it's in this area, it's deeper around inside of the brain, it's not the outside of the brain. Actually, these very hard to get into. And if you're getting into them, that's a real problem. You can cause more damage. What we tend to do is just control the blood pressure in the acute phase, bring it down to less than 140 over an hour, okay? And that then slows the bleeding down. You know, if you're on blood thinners, okay, we may give you a drug to reverse that drug. Yeah, we might, yes, in some cases neurosurgery, but not commonly. You know, in my time, I don't think I've seen anyone get neurosurgery for a hemorrhagic stroke for quite a few months. When it does happen, it tends to happen for the bleeds at the back of the brain because they can cause more pressure effect. And these patients actually don't have true neurosurgery. What tends to happen is they put in a shunt that drains because the brain can swell. So they put a shunt in to drain some fluid off whilst the brain settles. So that's the type of neurosurgery they tend to intervene with at the back of the brain, but it's not as common in my experience. The difficulty is you don't know it's a hemorrhagic stroke until you get to hospital. What you do know is you've got stroke symptoms. You get to hospital, we're rushing to do a CT scan. What I want to see is no blood. If I see no blood and you're within that time window, then I will deliver what I can deliver. The clot busting or the thrombectomy if I can. Okay. If I see the blood, I cannot do that. So I stop. So in a sense, yes, the damage is done, if it's as a simple answer. But as I said, there are things we can do. We want to reduce the burden of the blood carrying on. We've got trials. We've got a trial called TITCH3 at the moment where we actually give in a specific drug that kind of stops the bleeding. It's part of a trial for stroke therapy. Yeah, it's being done at Charing Cross. So we try and recruit patients into them. We're not sure if it works, but it's a trial. But most importantly, blood pressure control. If you leave yourself at home, which even though we don't know it's a hemorrhagic stroke, your blood pressure may well be through the roof. We need to bring it down to reduce the risk and the burden of that stroke. Yeah, so you can have a hemorrhagic stroke with low blood pressure because it's a different cause. Okay, so the commonest cause of hemorrhagic stroke is high blood pressure. Okay, however, there are other reasons. Okay, much more complex reasons, which I can go through now if you want me to. I'm very happy to do so. So one of them being something called an AVM, which can happen in younger people. So it's an arteriovenous malformation, so an artery and a vessel in the brain can kind of form a false lumen, and then that can then burst. Okay, so that you could have normal blood pressure, and that when that bursts, it gives you a hemorrhagic stroke. Okay, the management's the same from that aspect, but this is where neurosurgeons will come in. Because what they need to do, they need to clip that vessel or do something with that AVM. There's also something called cerebral amyloid angiopathy, which is something that happens, it's not common, it happens in older patients at least. I mean, it tends to be more if you're 70, 80, maybe later, but can be from the age of 50 onwards. As I said, it's not common, but can be patients who have had memory problems for a while, and somebody's diagnosed them as having dementia. And actually, those memory problems can be related to the CAA, which is basically they've got little microbleeds at the sides of their brain, and they are more susceptible to having hemorrhagic strokes. There are other causes. There's certain drugs that can make you have a bleed, but generally the main thing that we can change, because obviously these things we don't know at the time, but the things we can change is high blood pressure. That's why I'm here to tell you about the risk factors and what the importance of getting onto that to reduce our risk. So this is how I think about it. It's like just going back, leaving bleeds for a second. So we're talking about the clot. The clot, I think of it as blood clotting. We've got two choices. So thrombolysis, clot busting medications within 4.5 hours, which is what my 18-year-old patient had within 2 hours. Thrombectomy is up to 24 hours in certain centres. At Charing Cross, where I work, if you present within 12 hours of symptoms and you just have a plain CT scan and then want to look at your vessels, if we can see a clot in the right vessel, we can pull it out. Okay? If you present between 12 and 24 hours, we can still potentially do it if we've got the clot in the right place, but we need to do more advanced imaging. So we need to look and see that there's still tissue that we can salvage. But the key is get yourself to the right place quickly, and then we'll do our best. So causes, we've talked about high blood pressure. Take your medications. That's as simple as it is. Julie will tell you we've had multiple conversations about the blood pressure, but I'll let her tell you all about it later. High cholesterol, get your cholesterol checked and take your medications. I've got a lot of people don't like the word statins. I hear it commonly in my clinic, but I tell them that statins have been proven in many trials to reduce the risk of heart attacks and strokes and clots in the necks. Okay? If you have a problem with a statin, try a different one. If you have a problem with that, then we can try other medications for cholesterol. Diabetes, medications or insulin. Smoking doubles the risk of stroke. Giles, well done for giving up. Yeah? Needs to stop. Carotid vessel narrowing, that is relevant for patients who have had a clot. So if you've got a vessel that's here, that's furred up with cholesterol deposits and it's all craggy, what can happen if a clot is in the bloodstream? In that craggy vessel, it could stop, cause a stroke. Okay? So what we tend to do later is vascular surgeons can come and get rid of all that cragginess. Okay? Atrial fibrillation. Anyone affected by atrial fibrillation here? Interesting. 1 in 5 people on the older side tend to have atrial fibrillation. Interestingly, it goes unnoticed, similar to blood pressure. So some people may have palpitations, okay, but it's not common. Most of the time, people don't even know they've got it, but they present with a big stroke and a big clot. Atrial fibrillation is an irregular heart rhythm, so your heart is not pumping in a regular way. The problem with that is a clot can form at the base of the heart and go up to the brain. Okay, so nowadays in GP surgeries, we are encouraging them to look for atrial fibrillation all the time. So one thing that I can try and teach you today is feel your pulse. Who knows how to feel their pulse? Yes, okay. Feeling the pulse, very, very important. Take your, under your thumb, that area, just below. See what I'm doing now? Take the 2 fingers. You feel bump, yeah? So that's your pulse. Your pulse should be going dum, 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 dum. So regularly, okay? Was that good? So please, no one have an irregular pulse today because I haven't got an ECG. Right. So one thing that I would encourage you to do regularly is to feel your pulse. Feel it for 30 seconds. Okay? Feel that if it's got any irregular beats. Okay, so it could be dum, 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 something like that. That's not regular. No. So dum, dum, dum is not good. We want it regular. We want regular. So regular, you don't need to do anything. irregular.